He comes to us from Portland Street Medicine, Dr. William Toepper. Dr. Toepper is an emergency physician who worked in the Chicago Level Number 1 trauma system until 2009. He made his way to Oregon to live closer to forests and mountains and deserts and seas. He did his final shift in May of 2017 without a plan. Too young to retire, he took off a few months before discovering the practice of street medicine. Motivated by the work of others and the urgency of homelessness, he and 3 others created Portland Street Medicine, direct hands-on medical care for those living on the streets. 1.5 years into the project, this is his story. I'd like you all to please help me welcome to the stage Dr. William Toepper, Lessons Learned and Lessons Shared. Dr. Toepper, please join us.
Thank you, Dina. That was a wonderful intro, by the way. Who wrote that?
Thank you for writing that.
Yes, my name is Bill Toepper. William is my I'm in trouble name, so I'll know if you say William. That's bad. Yeah, John, is it okay? I prefer the floor. Is that all right with everybody?
Yeah.
Okay. John, you're a pretty sneaky guy. John asked me to come to speak to a group of people who are interested in social justice and a good audience, and didn't fail to mention the public speaking kind of focus of this group. And this is kind of my nightmare, being in front of a crowd. Now, which is not a good thing because the work that I'm doing does require speaking. It does require explaining what I'm seeing, what we're seeing, the work that we're doing. It is really the focus and part of the mission of what we're doing. So I appreciate the opportunity to come up here and speak. You can provide me feedback, and you can. I would appreciate that, especially the grammarian part. I love that. But I finished my work in emergency medicine, having a real interest in what was going on in the ED, what the things I was seeing, the people that were being housed for hours to days to weeks in the ED, the psychiatric patients, and I felt really quite powerless in this work, and I knew upon retirement I wasn't going to be really ready to retire professionally, but without a plan, as Dina said, I took a few months off, and I don't know. Seriously, karma brought me to a street medicine meeting in Allentown, Pennsylvania. I thought it was going to be a gathering of, we'll call it woo-woo providers, people doing, kind of side medicine. And instead, in this gathering of about 500 people, I met the most amazing people that were doing the work of centuries of providers before me, people who were actually providing direct hands-on medical care, often beginning with foot care. That's often where street medicine starts. And I wasn't aware of the science behind it either. Now, the science is young and early, but I wasn't aware that this was a true discipline in evolution. And I was compelled by the folks in the room. I was compelled by the work. I was compelled, I'm a Capricorn, so the science kind of brainy part of it, I took to it, and I thought, well, I'm going to go back to Portland, Oregon, because we have a crisis here, as you know, and I'm going to join the group. I figured, well, they're doing it in Allentown, Pennsylvania. They're doing it in Dublin. They're doing it in Jakarta. Of course, Portland's going to be doing it. It's that kind of a city. And lo and behold, yes, there's a lot of street outreach. Yes, there's a lot of social work. Yeah, there are a smattering of small providers that are doing a little bit, but nobody's really doing street medicine in Portland. And so I found a few friends. Well, I have friends, but I found a few friends that I knew were of like mind, and we started the program. Programs often start slowly. They pilot, they question, they kind of do the research, which is so important in the world, but Portland really couldn't afford 5 years of researching on how to dispense healthcare to the homeless. So we embarked immediately with knowing that there was risk to that. The big risk was we might be doing harm, meaning we may be engaging a population, but we may not actually be helping them, maybe helping ourselves, maybe being a good social media presence, but not actually helping those on the street. So we're extremely mindful up front that the work we do needs to come from the people that we're serving. So that said, we moved quickly. I already changed the name of the speech from 0 to 60 because it seems a little sexier than the original title. We got started. There we go. So it's always good to kind of feel out your audience, correct? I want to know in this room, how many people see people living in homelessness or like on a day-to-day basis? I assumed it was going to be pretty much the room. How many people, when they encounter these situations, just will call it an uncomfortable emotion, not necessarily, it could be guilt, it could be fear, it could be anger, it could be any emotion, but how many people, when they see this, experience that type of negative emotion? If you don't, it would be strange. And then when you come away from that, how many people have just that feeling of powerlessness? It's ubiquitous, right? And we probably don't share that with our friends, but it's important to know that you're not the only one feeling this way. So the question we have is, really, can a team of volunteer medical professionals with a couple of Band-Aids, a couple packets of Neosporin ointment, I don't get paid by them, and a street roots guide of local resources really make a difference? And if I say yes, what does that mean to you guys who are not medical professionals, who are living? How does it really help you or impact you? So I hope to make a case for both, yes, what we're doing is important, and two, what we're doing can help Portlanders in their daily lives kind of manage their own negative emotions and move beyond that. So that said, it's really important for me to describe what we're doing. So originally, John and I talked about maybe not doing a slide presentation, but it turns out what we do is very visual. So I felt important to have at least some photos. So you don't even have to pay any attention to the text, but the photos do tell the story in many ways. So what exactly is street medicine? Simply put, really the most important thing is it's basic health care to people living on the streets, in the forests, in tents, under the bridges, where they live. Yes, there are a ton of safety net clinics that are doing amazing work, but a chunk of Portlanders or anybody will not come in for various reasons. We hopefully will be able to get to touch on that. The emphasis of street medicine is what we call the rough sleeper. That's the person who's actually living outside, not in a shelter, not on somebody's couch, not even believe it or not, a rough sleeper, if you're living in a van or a car, you're not considered a rough sleeper. So these are arbitrary definitions, don't get caught up on that. But the focus of street medicine truly is the person living outside. Again, these are international practices, India, Latin America, Pittsburgh. And the models of these street medicine programs are on a spectrum. There are some folks that are non-medical that are doing foot washing. And then there are very vigorous programs in certain towns that are health system based that are about as classic as an indoor medicine program. But the bottom line is really we're meeting people on their terms. We're being invited. We're being asked to help. So that said, this is what our examining room looks like. We have no roof, as you can imagine. We do have a van that carries our stuff, but we don't do the work in the van. This is not a drive-up clinic with an examining room. Our examining room is the person's van, tent, where they're living. So why do we need to be doing this? Well, numbers. This is the old count of 4,177 people. One night in 2017 were living outdoors. The subsequent numbers have been pretty much identical, but the people that are living outdoors, we believe this number is way underestimated, by the way. There's the people that are living outdoors, there's a high burden of chronic illness, heart failure, untreated cancers, diabetes, just you name it, these folks are ill. This blew me away when I went into this. The average life expectancy of somebody living outdoors is about 47, similar to an American in 1890. So people are not only ill, but they're dying young, and they're dying of preventable things. Again, diabetes, hypertension, untreated cancers, yes, sequelae of drug use, but honestly, substance use disorder is a medical illness that has treatment, and these folks are not getting that. If you're a systems person, this costs the healthcare system a lot of money. I think, well, who cares about the healthcare? But the healthcare system is us, so we're paying for it. So there's a financial burden as well. And the reality is, when you have to find a meal, when you are shivering, going to your appointment next week for your cholesterol check isn't that important. So healthcare is not a top priority for people living on the streets. Just to let you know, we didn't invent this. This has been going on, as I said, for quite a long time. The gentleman on the left, his name is Jim Withers. He really is the father of modern day street medicine really in the world. He does a wonderful TED Talk. I don't have the link listed, but if you're at all curious after today about the bigger picture, go to the TED website and punch in Jim Withers, and you'll just be moved for, I think it may be a 30-minute talk. I highly recommend listening to it. What they found was the core of street medicine is that people are the experts in their own lives. That sounds kind of like, but isn't that how we live? I mean, when we go to the doctor, we're often told to do things, but we make our decisions on whether or not to get our cholesterol checked, or if we really want that mammogram every 2 years. So the concept of the person as the expert in their own lives, we have that. We're privileged. We have that. We can make those choices. But the folks on the streets, they take what they can. So we like to enable or empower the folks living on the streets to make those choices as well. And that can be to use drugs. I mean, using drugs is not good for you, but if people want to use drugs, or they need to, or it is in their blood, then I'm not going to tell them no. I'm going to, maybe talk about better ways to use drugs, safer ways, but I'm not going to stop them. The people make their own choices. I kind of touched on the rest of that. The other thing I think to point out is the work that we do is not, we're not saving thousands of people every week. This is a one person at a time deal. We recognize that. We do think that one person is really important. So we honor that. And finally, the work that we do, we're going to witness some really nasty tragedies, both, people dying, of course, but people making decisions that are really tough to watch and witness. But that is the work, and we just have to accept it. So just a little bit of a sidebar. It does often come up, what term do I use? Homelessness, houselessness, person experiencing homelessness. The bottom line is that's really up to the person you're talking to. The Street Roots group is very comfortable with using the term homelessness. Some people prefer houselessness because even if you don't have a house, you have a home, meaning your encampment is your home, your van is your home. The 4 people living in the little cave underneath the freeway, that's your home. So there is no right or wrong on that one. If in doubt, just ask the person. What we're just doing the care that we're giving is pretty basic. We do first aid, we do some management of some pretty simple chronic or routine conditions like urinary tract infection, bronchitis, strep throat, etc. We're not diagnosing cancer in the streets. We do a little bit of management of hypertension and diabetes. We're not primary care. We're working our way towards that, but we're not trying to replace a primary care physician on the streets. We do a lot of deciphering of medical confusion. People leave hospitals you guys probably leave hospitals with discharge instructions that are unintelligible. Imagine, not having glasses. So we do a lot of deciphering of medical confusion. Case management means we do a lot of getting people to where they need to be for their office visits, their clinic visits, their x-rays. We don't quite have the capability of doing it physically, but we managed to get people their bus passes, get neighbors to help assist them. We work with a lot of other groups like Union Gospel Mission that do a lot of street work as well. So we do a lot of collaboration that way. And the bottom line is, the main thing that we do is we show up. We're just there, and we're predictable. So that is core to this work. In Portland, what actually are we doing? We're going out Monday, Wednesday, Friday. We're all volunteer. We base our route on phone calls to us. We attend the weekly citywide street coordination call. So we get referrals from outside agencies like the police, TriMet, Portland Parks, and just various agencies. So we listen a lot to what's going on out there. All of our providers, this is generally physician, nurse, social worker, are completely vetted. You have to go through a background check. You have to get a malpractice inquiry. You have to get references. The standard things you would expect of any healthcare worker in a traditional setting. So the people we're sending out there are the real deal. And then we expect our volunteers to come out once or twice a month. So it's not a once a year deal. It's real. How are we doing? In last year, it's in our first year, we saw about 500 people, which I thought was pretty good. And then we're looking at about 1,600 for this year. Not huge numbers, but these are 1,600 people who are being seen for free, who wouldn't have been seen otherwise. So again, if you're that one of the 1,600, it's important. And we're building, so the numbers are, I think, significant, but they're just going to escalate. And we did flu shots last year, and we'll be doing them this year. We keep quantitative data, because you have to get grant funding and stuff like that, but we like to call it our qualitative data, the stories. So this is Boss. He's a homeless dog. He's one of our patient's dogs. He's super sweet. This is our first procedure. We took out his stitches. Because of patient privacy and everything, I don't have a lot of patient slides, but Boss consented to this one. We saw a woman, a gentleman approached us, did not fit the bill of homelessness, if there's a bill at all. Dressed well, very eloquent. Turns out he was a physician who fell into hard times, so he's living on the streets. And he asked us to see his wife. His description was a little bit like, she can't have this condition because it's just not possible. So it took us about a half hour to find her. We went to see her, and she's smoking her cigarette and laying on the in the tent. And I thought, she can't be very ill. Again, prejudice. Walked, kind of kneeled into the tent, started talking to her, and examined her abdomen, and it was rigid. Now, I know this is not our group of healthcare providers here, but a rigid abdomen, that's not good. That's what we call peritonitis. I'm sure you've heard of that term. Anyway, it turns out she had a ruptured appendix, was sitting on it for about 3 days, and probably another 6 to 12 hours, she would have gone down that sepsis spiral and died. So it was mostly timing, but the timing brought us to her, karma, and we were able to save her life, and she's now housed. They are housed. They're doing well. Someday I hope he gets into practice because he's a really good guy, the husband. Other things, dying indoors. It's just so difficult to see people with terminal conditions living outdoors. So we do our best, and we've had some great successes in getting people indoors in their last days. That sounds simple, right? In Portland, you have a terminal illness, there's hospice, everybody has OHP. You would think finding a bed for your last days would be the top priority. It's not, especially when you have dogs, especially when you have a partner. These are the things that we face. That it's called Portland Street Medicine, but it's a little bit more than medicine. So dying indoors is something we've witnessed. I think I'm gonna. I could do an entire hour on stories of the anecdotes and the wonderful things that we've seen, but I do want to. I'm just going to go on to. I kind of want to move on to. You get a feel for our program, but our program, I think, is compelling and hopefully will make you curious about what we're doing. But I want to kind of extrapolate what we're doing to non-street medicine folks to kind of take into their daily lives. So I thought, well, we call them learns, like lessons that we've learned from the things we've seen, the experiences, and beyond the experience, the programmatic learns that we've made, and my naivete into walking into the nonprofit world. These are some of the things I've taken away that have really helped me figure out how to do this work. Because it's hard. It's hard to drop $50 for a meal when you've just handed out $4.99 worth of oranges that people love, the little tangerines from Fred Meyer. That's what we give out. So how do you frame all this? And so these are some of the learns I've taken so far from the work. Number one, it's so easy to get caught up in the roadblocks. There are a gazillion of them. But our roadblocks are eventually our inventions. They're eventually our opportunities. They're eventually where creativity kind of comes into play. So I'm not going to say we've overcome every roadblock, but an example will be we don't have an electronic medical record. Huge roadblock for us. It's very difficult to communicate within the medical community without that. We know that we're not the only street medicine program in the country that has this roadblock. Somebody's going to invent an electronic medical record for street medicine programs. Maybe it'll be us. I don't know. We're not quite there, but these are the that's again, when I run into these difficult situations, I just look at them as some cool little millennial techie's going to figure this one out, and I'm going to be there. So I apologize for little was not a proper adjective. This is hard for me. Again, being Capricorn, being right brain, left brain, that organizational list maker type of person that I am. My world is chaotic. Life out there on the streets is chaotic, and I'm bombarded with medical questions and operational questions, and there's what do we do about that cop over there, and all kinds of stuff. And I learned very early on from a colleague, Juliana Wallace, who's the clinical director at Unity, the psychiatric hospital. She's like, you just got to let it go. This is the world, and if you want to stay in it, you just got to be one with it. So chaos is difficult for me, but as you can see, there's beauty in chaos, and just be a little left-brained or right. So that's a lesson that I've learned, and it really has served me well and our group well. And finally, oh, that's cool. Did I do that? If we're in the charity phase right now. We are really, for the most part, serving. And I know that's the theme of this morning, serving. And serving is, it is where you start, and it's honorable, it needs to be done. But if you don't move beyond the serving phase into the empowerment phase, and I'm not talking about empowering us, we're good. I'm talking about empowering the people that we're quote unquote serving. Then this is just charity. This is charity. And that's not going to really change anything for the folks living on the streets or society. So we know that. It's pretty much recommended when programs are really up and running, at least 10% of your energies, finances, and resources needs to be placed into advocacy, social justice. So we know that. We know that its priority jumps up later on in the grand scheme of things, but it's important to recognize that really up front. So that's, again, us, what we've learned. Hopefully, perhaps some of the lessons we learned so far will assist you all in the work that you're doing in your daily lives. But on a practical level, what can I do today, right? I'm moved, I'd like to watch the TED Talk, etc., but what really can I do today? And I'll begin by saying this phase, I'm going to break this down into 3 phases, is the toughest one, because this is the brain rewiring phase. What can I do today? Brain rewiring is not going to happen today, but it begins today, if you're so interested. So simply put, being let's just say a different Portland citizen today is a good place to start. And these are the simplest things, but these are probably going to be the hardest. Number one, when you're encountering a homeless person, individual camp, situation, whatever, the first thing, don't do anything but make eye contact. That is completely lost out there. And it's so dehumanizing and not very, it's not a proud place that we're at here in our country, or really in our nation right now. So the simple act of making eye contact with somebody that you perceive as homeless it's an easy first place to start. So that's, if I were to have a public health campaign, I would say make eye contact with your neighbors. That would be the place I would start. If that turns into a hello, great. I think it will. And it might not be today, but it might be 3 visits later. So encountering somebody and saying hello, you have no idea how important that is to the folks living out there, because they're the lepers. Unfortunately, that's where we're at. And then when you're ready, have a conversation. I say when you're ready, though, because there are stories out there, and there's a pretty good chance the conversation is not going to be 90 seconds. It might be a 20-minute conversation. And just enter into that phase, that conversation, when you're ready, when you have the time, when you have the mental space for it. You'll be pretty moved, I think. The stories are just mind-blowing. The physician living on the streets, for example. And then just repeat that cycle. If we stop there, this will be a better city. Next phase, this is kind of the mechanical phase of what can I do. And this is and I don't mean that in a bad way. This is really kind of a foundation, nuts and bolts of how we do this work, is what can I do tomorrow? You start giving. And your time, I think, is the most important entity to give. Obviously the money is important, but it's giving of your time. We all have too much stuff, so either giving stuff, holding drives, things like that. And I'm not talking about to us necessarily, but to the agency, organization, the church group of your choice. But giving of time, giving of stuff, and giving of money is kind of the mechanics, and it's there's no brain rewiring, luckily, with this one, so it can be done fairly easily, but there's a lot of work to it. The slide up left, that's me and the rest of my crew. The woman on the left, that's Sharon Myron. She's our county commissioner. She comes out with us regularly. I can't imagine a busier person in the city, but she comes out with us 2-3 times a year. I mean, which I think is pretty good given her status. So, and then finally, what can I do long term to really? And I will just say, this phase is you have to declare this yourself. It's when you're ready. So be patient. I didn't really enter into this phase until I was 58 years old. So this you shouldn't be guilted into this. This is when you're ready to kind of move beyond the sort of the charity phase of your day-to-day homeless encounters. So be patient, and you'll know when you're ready. It's not. It's karma. And you can't get there unless you're really taking good care of yourself. So that needs to be core to the work that you're doing, or the charity or service that you're hoping to provide. So when you get to that phase, if you do nothing, just share your stories. This is the stuff that moves people. Sharing your stories is really your stories, the people, whatever venue you choose to participate in, share that stuff, because it might seem a little trite to you, or you might share the same story 5 times in 2 weeks, but they're new to the listener. So share those stories. Speaking up, that one's tough for me, because I'm by nature pretty much a pacifist and not an arguer. But speaking up in your way is it's kind of how we go from charity into that empowerment phase, where the folks living out there feel like they have their voice because we're speaking up for them and allowing them to have their voice. And with this, change will happen. It's happened so many times historically. This is how the homelessness crisis is not going to be fixed by the feds. We know that. I mean, even good feds didn't do a whole lot. The homeless crisis is not going to be a mayor's office funding budgetary thing. It's not. It's going to happen from the folks out there, and they can't do it if they're not alive. They can't do it if they have trouble speaking because their heart failure is getting in the way. And they can't do it without really good allies, and that's us. So that's, bottom line, when in doubt, just do the work. It'll pay off. That's our program. It's kind of our philosophy. We're hoping, in the end, we see changes in our city over the course of months, years, decades. And if you have any questions, tap on our website. Send us an email through the info link. It doesn't come off that well. Our Facebook presence is pretty good. I'm not a big social media guy, but we get a lot of Facebook traffic. And there's the posts that our media guy puts on there are really, really very accessible, and they mean a lot to everybody. So tap on Facebook if you're on that. And then finally, if you see somebody that you're concerned about, call us. We're not 24/7. We won't be there in 10 minutes. We're not crisis response just yet. But that phone number, which you can't see, but it is on the website, 503-501-1231. Call us, leave a message. We will probably be able to see that person within a week. If you call on a Saturday, we do most of the work on Friday, but we might be able to see them on Monday, Wednesday. So the groups like this is kind of where we get our business, and so don't be afraid. That's us. That's me. I would like to hear from you guys as to programmatic questions or really anything. I'd like to open up the floor. Yes, sir.
A few slides back, what can we do tomorrow? Give some time, give some stuff. Those little detail on those two questions for people who are not medical professionals. Are there opportunities to give time? And if there's stuff you need, what kind of stuff do you need?
That is the number one question I get, and I promised myself next time I walked into a public speaking venue, I'd have the perfect answer. I don't. First of all, it's exciting work, and everybody, many people want to come on board. If you can imagine, a van full of 20 volunteers is not very good for the scared, frightened. So to answer your question, we're not quite at the capacity to bring on non-clinical volunteers in any way right just yet. We're developing, we have a new volunteer manager, and we're actually going to have our first hire very soon. And the first priority is going to be how can we utilize this public wave of interest in terms of time. So right now, stay tuned. I'll put it that way. It's forthcoming, and that will probably early on take the form of drives, like equipment drives or medical supply drives. A great example, have you guys heard of the event called Cranksgiving? It's an annual event that takes place, I think, the Friday after Thanksgiving. It's a bicycle-based group, and they do a scavenger hunt. And last year they dedicated their event to us, and our medical supplies for a good 6 months of last year came out of that event. So that will be that is in the very near future in terms of stuff. And again, mostly pay attention, and certain skill sets, particularly with regard to administrative skills like finances and budget and all that. If you feel like you have a certain skill set that might aid a fledgling early nonprofit, please, in the email, there's a contact link. There's a little place to type in some verbiage. That's the place to put it. So, yep, John.
Bill, would you be available to take some questions after the
Absolutely.
After the meeting?
Yep.
Okay.
Yep. Yeah, because I meant to say that. Public speaking 101, don't go over your time.
Fantastic. Dr. Toepper, again, I think the key is that he just raised our awareness. We have to